Very well. Thank you very much to all of you for coming on time. We will surely have more members of the audience incorporating. And on behalf of VUMI, we would like to give you throughout this month of men's health the welcome to this webinar, myths, realities, and novelties around prostate cancer. For those that don't know me, I'm Dr. Alejandro Roman. I am in charge of suppliers as director of the company of VUMI. So thank you very much to each and every one of you from the regions that you're presenting from. And good afternoon towards the right of our planet, and good morning towards the left of our planet. I would like to just give some initial indications to all of you so we may have an excellent webinar throughout this day. And I would like to inform you that this session will be conducted in Spanish with simultaneous translation into English and Portuguese. This webinar will be conducted in Spanish with interpreter on live, simultaneous interpreters to transmit on live towards English and Portuguese. And I will be providing you with the instructions for those that want to listen to this presentation in English or Portuguese. Well, these are the instructions for you to join these options. So in the screen, you may see the indications in your different languages. Remember, we will be conducting this presentation in English or Portuguese, and the presentation will mainly be conducted in Spanish. And also, please do remember that you will have a very important option that you can start using from the beginning of this webinar, which is an option of Q&A, a question and answer section, questions and answers. This option will be in the bottom of your screen, so you may communicate your questions towards us so we can kindly respond next to Dr. Wilmer and the team from the International Hospital of Colombia, Hospital Internacional de Colombia, will be providing towards the end of this presentation. So once again, please do remember that in order to respond to all of your questions in an organized manner, please use the Zoom Q&A tool. Very well. To begin, we will be presenting Maria Paula Cornejo. Maria Paula, if you could please turn on your camera. Maria Paula, welcome. We have a panel that is integrated by VUMI authorities and also authorities from the Hospital Internacional de Colombia, International Hospital of Colombia. Maria Paula is the International Commercial Director of the Hospital Internacional de Colombia and the lead of the international department in charge of the alliances with insurance companies in Colombia and also internationally. As a function, she will be elevating the services to the highest level within an institution that, as you might all know, is one of the best institutions at a Latin American level and obviously at a South American level. So welcome, Maria Paula, Dr. Wilmer. Thank you very much for joining us. And Maria Paula, the voice is yours to be able to present the doctor and to talk about the webinar that we will be talking about, of course, handling the presentation towards you. Thank you very much, Dr. Alejandro. Good morning to all of you. As you might know, my name is Maria Paula Cornejo. We are located in Bucaramanga, the beautiful city of Colombia. And today, it is a matter of joy for us and honor to present Dr. Wilmer Rivero, who is one of our best specialists with a great and broad experience. He's the head of our urologist department. He's a urologist and androgenist, and he has been in charge of important positions in the Colombian Society of Urology. It's also a matter of pride for us to say that from the international department, we have had many international patients that come from around the globe for different specialities, and one of them, which is the one that is led, is the one that is led by Dr. Wilmer. So welcome to each and every one of you. Thank you for being with us in this space, and we will be more than pleased to receive any of you whenever you please to visit us. Dr. Wilmer, the word is yours. Dr. Wilmer, you may start sharing your presentation to give a start to this webinar, and aside of that, welcome. Thank you very much, Dr. Roman, Maria Paula. Thank you for your kind presentation. And to all of those that are currently connected at the moment, a warm greeting from our city, reminding you that our city is a small city in Colombia, but it's had a populational growth and a growth in everything that corresponds in terms of the health system and health attention, and also giving a perspective towards international services. So it's a matter of interest and honor to be able to attend you all, and we send you a warm greeting, just as we always do here in Colombia. And we're pleased to be able to share with you our experience and our services for whatever you require. My name is Wilmer Rivera. I am a urologist. I'm also an andrologist and specialized in reproductive health and in sexual health. And I'm also a surgeon of kidney transplant or renal transplant, and one of the surgeons of the national network that works with this institution and that on a daily basis provides this service towards the region and the nation. On many occasions, we do need to provide these organs for people that are from outside of our city of Bucaramanga. Today, I am grateful for this invitation and for the opportunity to discern around the matter of prostate cancer, that it's a matter that affects us in our locality in Colombia. We do know that this is also an illness that affects all the world, and we want to talk about it, especially in this November month that is so important for the world, and also to remember the importance of early detection and remind you of the importance that there are treatments that could cure this if it's detected in an early manner, and that unfortunately, if we do not have an option of early diagnosis, the technological innovation and the pharmaceutical innovation has allowed that even if we cannot cure this illness, we can offer some years more of life, quality life, for those that receive these innovative treatments. So welcome. And we would like to simply remind you the matter of the prostate cancer represents one of the main public healths around worldwide. It's a solid neoplasia of the prostatic gland that at the moment is considered as the second most frequent cancer worldwide. And it's the same reality in our country in terms of statistics. And if, it has tried to decrease in the index of mortality because the early diagnosis and the different modalities of therapy have allowed us to be able to decrease that mortality, but it's still in the top 5 in the causes of mortality in terms of cancer around the world. I would like to remind all the population and the insurance companies that the incidence is still very high in terms of tumors. We know that there are many etiologists from the genetic side, the environmental area as well, that makes us be aware of the importance of promoting the health from our insurance companies, our hospitals, and from our health system in general to be able to impact in this incidence and its complications as well. Normally, the prostate cancer is a pathology that is usually common in people that are over 65 years old in 90% of the cases, but also as the decades go by, we're starting to see younger patients that are suffering from this. Therefore, it is very important to insist in having an early consultation. We hope that before those 50 years, when in the family there have been backgrounds of prostate cancer, and in those that are over 50 years of age, when there is no symptomatic illness and when there is no background in the family in terms of prostate cancer. So here we have some tables to make a discrimination worldwide, Latin America, the Caribbean, and the United States, how in all the different localities, when we look for the statistics, it's definitely one of the most frequent cancers that reported worldwide. that it's the second most common cancer, as we mentioned, and more than 1.4 million patients are diagnosed once again every year. So this becomes in a 14% of one of the cancers around the world. We have been able to diminish this rate of mortality, but it's not invisible. It's 375,000 deaths annually around the world due to this illness. And this is why we have this importance and highlight the importance of having an early detection. In Latin America, from this 1.4 new cases diagnosed annually, we have 135,000 new cases. And Brazil and Argentina have the highest incidence, with rates above 60 cases per 100,000 men. And normally, the mortality that has been seen in these cases are due to late diagnosis, and obviously because there is a difficult access to primary medical attention and then specialized medical attention, and also to the acquisition or being capable of receiving any kind of therapy, be it surgically, radiotherapy, or pharmaceutical therapy for the control of this illness. In the Caribbean, as we might all know, there is also a higher index of Afro-descendant population, just as in Africa. It also increases the incidence of the malign tumors. And we know that in Barbados and Jamaica, there's a report of more than 150 cases per 100,000 men. This is associated to a genetic predisposition. And once again, in our Latin America, in the Caribbean, and in the countries of the third world countries, the access to health attention can make that there's a delay, and this late detection could, of course, forbid or could create an incidence into the access of treatment. In North America, the estimated calculation is of 288,300 new cases in the year 2023. This is a high number of patients that year by year have been presenting and diagnosing in the United States. And here it's a bit higher in terms of the total volume of cancer in general. It could represent up to a 26% of all cancer cases. Worldwide, they say that it's a 14, but in the United States, it could be higher comparatively with all the other cancers that could be present in the body. And the early detection and the improved treatment and makes it a pillar in terms of the treatment for health services, and the insurance have been able to create an impact as well in the mortality. The development of technologies and specialized centers of cancer treatment allow that when the patients have a treatment or are diagnosed, they can access better treatments. This is our statistic in the case of Colombia. It is determined that up to a 25% of the tumors that are diagnosed, once again, in Colombia, could be represented by prostate cancer. The incidence is 49 cases per 100,000 men. Annually, there are about 12,000 new cases of prostate cancer in the country, and it has a mortality rate of 3,200 deaths per year due to this disease. So through the Colombian Society of Urology, we have a need to be able to give early practices of detection, promotion of health, to be able to detect this on time. And fortunately, the performance of the centers of medical attention and the specialized centers in cancer, especially in hospitals of a high level, like where we develop our activity, have allowed to offer effective and early treatments for this disease with a high index of success. This is a plot that simply demonstrates the proportion of diagnosis worldwide throughout different regions of the globe. And well, it's just informative. So explaining one by one, this chart would be a bit complex. So talking about myths and realities, you might all know that there has been a discussion for years, if it's not decades, around the usage of digital rectal examination, DRE, for the diagnosis of this illness. And effectively, there have been conversations to know if the DRE is eliminated within the framework of diagnosis within the prostatic illness. And we must say that even if the prostatic antigen is much more sensible to be able to diagnose the prostate cancer, the DRE is still being practiced worldwide due to the cost effectiveness that it can have added to the prostatic antigen to be able to make a detection of prostate cancer. We know in general terms that a prostatic antigen can have a diagnostic prediction between the 70 and 80%. Nonetheless, if we want to increase this diagnostic possibility, the addition of the DRE increases up to a 15% the diagnostic capacity of the prostate cancer. So definitely, it is still recommended within the guides of diagnosis and management of prostate cancer worldwide. Studies have tried to reassess how other diagnostic tools like magnetic resonance, the MRI, the contrastic periodontilometry, the prostate ultrasound, and other lab exams could avoid having the DRE, the digital rectal examination, but the cost effectiveness, especially in our Latin American societies or Central America, make that the evaluation of prostate cancer only with advanced diagnostic studies from labs of radiology are much more costly, and the effectiveness is not increased in a significant manner. Therefore, the conclusion of why we should keep practicing this is because definitely the accessibility and the speed of a diagnosis with DRE is high, the cost is low. And what we look for when we definitely attach into the management guides and the diagnosis of cancer worldwide is that we must look through DRE, irregularities, nodules, or induration that could suggest that there is a malign illness in our prostate. Additionally, we would like to remember that if we feel any alteration in our prostate, any nodule, any irregularity, it would mean that the illness is already in an advanced stage, and obviously this is related with the prediction of the illness, the risk of progression, and the risk of not having the best outcome with the treatments that we may offer to the patient. Therefore, it is the way of being able to justify that we must continue with the diagnostic process, mixing the DRE and the prostatic antigen within our patients. And now we will start talking about the prostate biopsy. It's a matter that has been tried to be counteracted through different medical specialities. And the main conversation or discussion that has been held is around the possibility that a prostate biopsy of malign cells, where they extract this malign cells, could be planted in the tissues around the prostate or other structures. Ideally, this has been studied in an important manner with multiple studies, and there hasn't really been a justification nor a demonstration that the prostate biopsy could increase the risk of dispersion of this malign cells in the peripheric organs to the prostate, nor has it been associated to the increase in the size of the illness, nor an increase in the fact that the illness will change of its stage. Therefore, the prostate biopsy did not generate any risk of increase in the illness, nor alteration in the forecast of the illness, according to studies performed worldwide. Although it is important to explain to the patients and other health professionals that perhaps have had that uncertainty if they must perform a biopsy or not, we must remember that the biopsy has mainly two risks, which are infection of the zone, of the prostatic zone, urinary infection, and urinary bleeding, rectal bleeding, or hematomas around the prostate. These are more local complications than systemic complication, and therefore we must not forbid ourselves of performing this. And the main justification of making a prostate biopsy is that after the screening, the initial screening that is done with the prostatic antigen and the DRE allows us to know that there's a suspicion of a malign illness, and that's why we need to take a sample of the prostatic tissue, trying to demonstrate that we have malign cells within this tissue. Aside of demonstrating that we have these malign cells with the biopsy, we can also determine which is differentiation of the pathology within the cells to be able to know if these are illnesses of a low risk, intermediate risk, or a high risk, and therefore be able to discriminate which will be the best therapy for the patient. Therefore, a patient that has a suspicion of prostate cancer through an abnormal DRE, digital rectal examination, due to an increase, a significant increase of the prostatic antigen around 10 nanograms per milliliter, will have the indication of a prostate biopsy. Equally, if we don't feel an alteration in the digital procedure of the prostate, nor do we have an elevation above the 10 points of the antigen, but above the 4 points between 4 and 10, this would equally guide us to have an MRI when we have a suspicion that is not so high, but sure, when we have 4 and 10 of antigens with a normal digital examination, we perform an MRI. And if the MRI that we will be talking about later on, if this MRI shows us any alteration or any suspicious zone, would also indicate us to perform a prostate biopsy. And these prostate biopsies can be done rectally. They can also be performed through the perineus, which is another alternative technique that has been coming along throughout the last years, trying to avoid the contact of the sample and in the ultrasound with the rectal channel to avoid any risk of infection, and it can be done through the perineal side. Now, the prostate that we observe is done through the different lobes, but the operator or the surgeon will determine how many samples will determine to take according to the findings of the ultrasound, according to the findings of the MRI, if they have been performed previously. And this is how the samples are taken. And after a blocking has been done through the prostate with anesthetics to try to diminish as much as possible the uncomfortableness of the method of this diagnostic tool. This is the transrectal ultrasound, where the volume is determined. It is determined if there are any kind of suspicious injuries. Normally in the ultrasounds, the suspicious injuries are hypoechogenic. And to make it easier, these are injuries that are seen black within the prostatic tissue. And these are also injuries that are described within the report of the ultrasound with the purpose that the urologist or the specialist that is observing the case determines to take the sample with fortune of this same area. Now, talking about the multi-parameric magnetic resonance of the prostate that I mentioned in the previous slide, we must also remind that this has been one of the most important advancements in multi-diagnosis procedures of the latest decades. The MRI, magnetic resonance imaging, has been the diagnostic test, an imaging test that allows us to solve those diagnostic suspicions and have allowed us to also diminish the frequency of the performance of unnecessary biopsies, because the MRI has a capacity in diagnosis of these injuries, of those suspicious injuries, in an important manner. And the different centers around the world and then the specialized centers around oncology have allowed to determine different patterns in terms of images to classify the injuries of the prostate and injuries that are lowly suggestive or highly suggestive. And towards the end, they are classified within the classified that is very well known as VRETs, that just as in other organs, there are also similar acronyms, but the VRETs is associated with the capacity of diagnosing a good or a bad illness. Now, the VRET injury go from 1 to go from type 1 to type 5, knowing that 1 and 2 types are very low, have a low probability of being malign. It's more probable that they are benign. And the third type are indeterminate. And according to what you find in the rectal analysis or at the level of the antigen, you could determine just a strict vigilance. And the 4 and 5 are injuries that are highly suggestive of having a malignant injury and indicate us to have a directed prostatic biopsy. And if there are devices of technological fusion or cognitive fusion, which is simply taking the sample, directing the most quantity of samples to the identified nodules within the resonance, when we don't count with the technology of MRI that do exist in multiple centers of diagnosis for this illness. We would also like to remind you that the diagnostic probability and the sensibility of this resonance is above the 85%. Therefore, it's a great aid to be able to perform a detection and a biopsy, and also to be able to avoid the probability of performing biopsies that are not necessary and that put in risk a patient into pain, bleeding, or infection. Additionally, in the matter of the MRI, as it's a pelvic study, we could also identify the presence or absence of ganglia called medically adenopathies at a pelvic level that could suggest that there's already a commitment outside of the prostate of this malign illness. And it also allows us to precise and plan the treatments, be it surgical procedures or radiotherapy procedures, to try to improve the index rates of these and success of these treatments. Equally, through tradition within the schemes of diagnosis and what we call the battery of tests to be able to perform the diagnosis of the prostatic illness, we require, or we need to remember that within the schemes, we have the actual CT image and the bone scan as basic tools, conventional tools for the study of the prostatic illnesses. Obviously, the usage of technologies as the BERT scan that we will be the PET scan that we will describe later on have allowed that in different centers, those basic images of tomographies and gammographies that are less sensitive than the MRIs and less sensitive than the PET scan may also play an important role in the diagnosis of this illness in those centers where they don't count with advanced technology. And that, of course, these technologies cannot be discarded, and that we need to have at hand to be able to know up to where this illness is reaching, if it's performing a metastasis, because if we don't have complementary studies of extension, even if they are basic, like these images of actual CT image and bone scan, we could be submitting to surgical treatments or radiotherapy to patients that don't require these kind of treatments. So we should not leave these basic exams to a side. They're fundamental in the study of the extension of these malign prostatic illnesses, and that's why we also wanted to mention them. And now, talking about the PET scan, which has definitely been the revolution in the latest decade and the struggle against the prostate cancer. This is a technology, a complementary diagnostic technology that is being studied even more, that initially emerged as a test to be able to try to identify those patients that had prostatic relapses, and we wanted to know where the relapse happened after there was a curative treatment. But throughout the years, the diagnostic capability that the PET scan is acquiring, especially with the marking of the PSMA, have allowed to look for the advanced centers of diagnosis of prostate cancer to allow them to know how they can be used, not only to study the relapsing or the recurrent illness, but also to be able to use it in the initial stage of the illness to be able to plan up to where we can treat the patients. And we have spoken in different centers and international congresses that the PET scan will definitely start gaining even more diagnostic capability, and it will have a greater use in our daily lives for the diagnosis of the prostate cancer and its complexities or complications. And definitely we must have it at the hand, just as we have it here in our hospital, because we are having a greater need of this tool. And we have also demonstrated that if we use it, we will be more sure about the treatment that will be offered to the patient, be it an initial treatment or a recovery or rescue treatment, and also the quantity of patients that before used to be taken into initial treatments that were not necessary because the illness perhaps just was an advanced illness, and we're avoiding them to suffer from pain, from consequences, if these treatments are not required. So it helps for those that will be cured, but also to not perform treatments that are not necessary in patients where there's no localized illness, and that definitely nor the radiotherapy or surgery would be the best option. Therefore, we have already advanced about the epidemiology and the presentation of the illness, about the diagnostical tests to be able to arrive to the precise or accurate diagnosis of the prostate illness. And I would like to talk more about the treatment. It's very important to close this part of the diagnosis, that it's important to remember or to remind those patients that could be hearing us or the health providers that we must definitely insist in a fast diagnosis, and especially in those patients that are asymptomatic, because the population in general worldwide associates symptoms with cancer, but there are people that go to the treatment, to the diagnosis, but they don't remember that what as urologists what we offer is that the cancer does not give symptoms. Therefore, we need to search. And equally, the big prostates not necessarily will have malign changes. And when the people receive an ultrasound and they tell them that it has a good side, sometimes the people are relaxed, they don't look for aid, and they don't try to advance in the diagnosis of cancer. So let's remember that the cancer is asymptomatic. The cancer must be looked with all these diagnostical tools, even if we're perfectly well in terms of health, because when cancer already demonstrates symptoms, we're surely in a much more advanced moment of the illness. And unfortunately, we have lost months or years in the treatment, and the rate of survival or forecasting of the illness will be much more difficult or complex. And when we focus the treatment, once we have a confirmation of the diagnosis, we must remember that the treatment has different options, but also these options depend on each clinical case. At the moment, we couldn't mention that we can operate all the patients, nor that we could irradiate all the patients, or that we can perform treatments with hormone therapies or chemotherapy, because definitely if we're talking about a general term of the diagnosis has to be very precise, creating sums from the clinical area, the biochemical area, looking at the prostatic antigen, the image diagnosis, and the part of the pathology of the biopsy, the age of the patient, and the life forecasting that we could have. And the sum of all these different areas will give us which is the framework of the best treatment. I definitely do believe that once we have this illness and we have centers that are making an effort to do a better work and procedures, we do to have all the tools and diagnosis and treatment to give a good diagnosis and plan a good treatment. Unfortunately, in different sites, we could have the possibility that not all the tools are present, and this will also allow us to make intermediate diagnosis. And in that case, the treatments will also be intermediate because they won't be complying with the final purpose, which is making a directed treatment, looking for a rate of success and satisfaction within the patients It is really significant. Before the treatment per se, I would also like to talk about chemoprevention. And this could be one of those questions that perhaps could be done later on. And it's that for many years, it's been spoken in terms of knowing if there's an option to diminish the risk of prostate cancer. And what we must explain, according to the experience, and additionally, according to what's been studied worldwide, is that there's a genetic base that is unmodifiable. And that makes part of understanding that the chemoprevention will probably not be 100% effective. How has this chemoprevention tried to be performed? For more than 60 years, it's been known that prostate malign illness depends on the masculine hormones, especially on the testosterone. And chemoprevention has tried to search the how through this hormonal flow that feeds the prostatic tissue, there could be a diminishment of the cancer or risk of cancer. And what's been tried for years, and I could talk about more than 20, 25 years, is how to give in testosterone inhibitors that we can know as the finasteride or the testosteride, and be able to look how we can diminish or decrease the cancer risk. Therefore, there have been great studies, big studies, and the purpose of these studies was to search or to observe as the pharmacological therapies inhibiting these hormones. The purpose was to see if they really had an impact on the reduction. And there has been a search in the literature worldwide, and there hasn't been found a utility or precise usefulness in those patients that had a high risk of illness or those that had a differentiation of aggressive pathology. And within the study and the literature and the investigation, there hasn't been a significant difference. There have seen that there is a slight diminishment of the risk, and those that had a low risk, intermediate risk, and those patients that are of a high age. But also, after the magnifying glass was put to be able to see which was the percentage of the decrease, it was observed that it was low, and it's not considered as an index or a preventive management plan, the chemoprevention, based on the inhibitors of the 5-alpha reductase, which are the blockers of the testosterone. Therefore, we would also like to call you all in the attention to mention that this has been a topic that has been spoken about broadly, but we must be careful in the useful of these treatments, because aside of not having a significant impact on the decrease of cancer, when we block the masculine hormones, we have secondary effects of between a parentheses of an andropause or hypogonadism, because the patients may suffer the secondary effects of that hormonal blocking. And we do know that our testosterone is an engine for our corporal functions, for our memory, for our bones, for our muscles. It demonstrates the strength in our day by day and our sexual animosity and our sexual performance. Therefore, it's very important to remind you all that we must not take treatments empirically, and equally also remind that even if a doctor prescribes them, the percentage of benefit for the protection of this malign illness is low, and it does bring important complications in its daily performance and the vital functions. Now, in terms of the treatment schemes, I would like to remind you all that the treatments can go from the conservative treatments that are described as or denominated as that watchful waiting or active surveillance. And these are the treatments or schemes that are offered to the patients where there is a low possibility of progression. To those patients that have antigens that are below the 10 points, with a pathological variety of the cancer that are well defined and they have a good forecast, or patients that where they don't feel any kind of nodulation in the prostate when the physical exam is performed, and the images show very small and confined injuries that are defined within the prostatic tissue. Therefore, when we define what treatment plan is going to be carried out for the patients, as they are all so different, the sum of the different scores, age, the life expectancy, what is felt in the digital rectal exam, the level of the prostatic antigen, the characteristics of the pathology, the biopsy, the images, all of this summed must allow us to think, what risk does a patient have for his life and his health, and in that way be able to know what we can offer them. So in this case, we just want to mention that the conservative, in general terms, must be offered to those patients that perhaps don't have a long term of life expectancy, a long life expectancy due to the base illnesses, or if the patient has more than 10 years of life expectancy, but they're asymptomatic, they don't feel any, there's no strange digital rectal examination feeling. The result, the MRI shows small injuries confined and low antigen, this patient that has all the features that he will go well with this illness, despite that it's a bad illness, surely that patient could go into a conservative framework of vigilance with precise follow-up with serried examinations of the prostatic specific antigen, the PSA. There must be constant exams, at least for the first 3 years, and MRIs to be able to see that the illness keeps having the same features. And if there's any change, perhaps we could consider a change of strategy. But if the illness keeps going with the base features, just as when they began with the management plan, that patient will be able to proceed with strict follow-ups. When we do not have the features of conservative treatment, or the patient, and many patients, of course, after knowing the news that they have malignant disease, don't have the tranquility to be able to keep the calm and the vigilance we need, or the surveillance we need to offer to these patients any some other treatment. And even if we have a good diagnosis, we need to try to have a healing intention. And if it's an illness with good characteristics, the patient with a healing intention will perform very well. Now, which are those active treatments with a healing intention? They are mainly given by the radical surgery of prostate, or due to the radiotherapy treatment. Now, normally, as the years go by, and the studies have demonstrated that in many occasions the radiotherapy is already comparable with the outcomes of surgery. Nonetheless, an important point of discrimination when we have a patient who needs to have an active treatment with the intention of being cured must be that the patient in first place has the possibility of being cured with the illness, and there are different worldwide tomographies to be able to see which is the sum and which is the percentage of healing. The age of the patient must also be observed because when the patient has more than 70 years of age, have a greater index of complications, especially in the matters of incontinency and erectile dysfunction. So all these expectations of the patient, all the risks that the patient might have, also add some scores to be able to discriminate which is the best option of curative or healing treatment. And well, jumping into the second step of treatment, where we have a patient that we need to heal and who that we offer that healing intention to, also presents those other patients that do. We must also take into account that there are also patients that do not want to have a healing treatment. They don't want radiotherapy nor surgery. So we can offer a systemic palliative treatment with a systemic approach with the purpose of stabilizing the illness and diminish the progression of such illness. But it's also offered to those patients that when the diagnosis is advanced and there is no healing possibility because the images, because the pathology and the antigen, and perhaps with all the different study complements, it's been demonstrated that the illness is already extended throughout the body, will obviously show us that there is no possibility of treatment, and the systemic palliative treatments start going into the most important role. So in terms of the active treatment through surgery, we have mainly the radical prostatectomy, prostatectomy. It's a surgery that has been done throughout many decades, that has been perfected throughout time as the different implementations and the different advanced technologies have arrived, like the laparoscopic surgery. And at the moment, the complement of this robotic surgery has allowed that for this radical prostatectomy have allowed to diminish the illness in the patient with a high level of effectiveness and with less feared complications, because perhaps from this treatment what is more feared are those complications that come from the surgery, like the urinary incontinence and erectile dysfunction. The surgery by itself also have complications due to the procedure. It's a long procedure. It's an oncological procedure because it's also a pelvic procedure. And obviously the risks of the surgery, like the bleeding, infection, the thrombosis, the pulmonary embolias, and the collections of the lympha once the pelvic ganglion dissection has been done, will also bring something that is inherent of the surgery, independent of the zone that we're operating. But urinary inconsistency and the erectile dysfunction that is present to the patients due to the injury and the urinaries and in the cave erectile elements make the patients to decide to have the surgery or perform the surgery. And as surgeons, we must also take into account that consideration to know towards whom we should perform this procedure or not. And with the arrival of technologies of robotic laparoscopy, these complications have been trying to be decreased. And with the studies that have been reported throughout the last decade, it shows that the robotic surgery of minimum invasion, like the laparoscopy, have also been able to show the diminishment or the decrease in functional functions in matters of urinary incontinence and erectile dysfunction. This is why the worldwide centers have tried to increase the technological capabilities to try to offer these benefits to the patients. Normally, after a surgery is performed and that it has a success through whatever method is used, open, laparoscopic method, or robotic, what we look is for the prostatic antigen is not detected because the prostatic injury has been removed, but there could be values as well that are below 0.2 that must be kept in surveillance when they're present. And it's also considered that the relapse of the illness or the recurrence of the illness is present when the antigen has more than 0.2 nanograms. And to start closing the matter of surgeries, and to be able to create a conclusion in the matter of the radical surgery is very important, I believe, for the medical part and for the administrational side and the management as well. It's important to mention that the big differences in the success of the surgery with radical prostatectomy is not only determined by technology, it's also determined through the experience that the center has where it's being performed and the surgeons that perform the procedure. There has been studies and comparisons of surgeons that have a high volume of open surgery or laparoscopic surgery and robotic surgery, and probably the outcomes are quite homogeneous. Therefore, it's not the technology per se that could bring the benefit of diminishing the complications, but the expertise of the medical center and the surgeons that are performing it. And we go from the surgery to talk about another treatment with healing intent, in this case, the radiotherapy with healing intention. It's a local treatment, usually painless, non-invasive, that as well throughout time, we're having tools and advanced machinery that have impacted the success of the therapy and diminish the level of complications that are mainly derived due to the injuries of the organs that are around the prostate. Now, the main complications could be chronic diarrhea, proctitis, cystis radica, and incontinence and impotence, and the urinary fistulas are also taken into account that were present in previous method, but with the new methodologies, they are decreasing. And the incontinence and impotence could also be present, but the incontinence is dramatically less than with the surgery, and the sexual impotence is quite similar. However, it starts presenting itself in a later manner. When there's a surgery and there's going to be an incontinence and an impotence, the effect is shown immediately. With the radiotherapy, it starts emerging as time advances. Just as the therapy could also take some time to perform its healing effect over the malignant cells of the prostate, the complications also come in a slow and progressive manner. Now, the schemes of radiotherapy is a special topic that is handled by the radiotherapist oncologist, but in general terms, just to explain to all of you, there are some charges of radiation that, depending on the patient, the illness, and where the therapy wants to be extended towards, because it could only be the prostate or it could be extended to the ganglia or other organs around, well, that dose will be calculated by each one of the radiotherapists, and it's also calculated by the different centers because each center has a different protocol. And what is done is also to perform fraction therapies, some with a low fractioning and others that are highly fractioned, looking a balance between the success of the therapy and the decrease of the complications. Now, in terms of the hormotherapy that is being shown here, now the hormotherapy is used usually as a complement in terms of the treatment with the radiation, and what this therapy tries to bring some sensitivity to the malignant cells so the radiation has a better effect. Now, the usage time 5 years back was of 2 years for everyone, but as the effect and the benefit has been studied, there has been an attempt to decrease the usage of these hormones that co-help in the treatment to also try to diminish the secondary effects that they have. Because when we make a hormonal blocking of the testosterone, it generates a pharmaceutical castration that has the secondary effects of any castration, the diminishment of the strength, memory, less strength and animosity to perform activities. And equally for the sexual side, there's a huge decrease. And the patients that have a cancer of an intermediate risk or low risk, it's been diminished. And those that have a low risk, it's not even being considered to make an hormonotherapy, and the radiotherapy is the only treatment for healing. Now, in the matters of the assessment of the relapse, that's done with a chemical analysis of the prostate, knowing that we need to reach an index of the nadir. Nadir is the lowest level of prostatic specific antigen that can be attained after the next 2 years of the radiotherapy. And what it's being looked is for that level to be taken into account in a precise manner, to be able to make a follow-up, to be able to know how this level is behaving, because a progressive increase of that naive index will let us know if the illness is persisting, if it's having a recurrence, or if the patient is healed. And finally, talking about the advanced cancer, or just as I mentioned, for those patients that do not want to submit themselves to radiotherapy or surgery with the intention of healing, because we see this in our day-by-day life in the consultations, these patients that are taking to an androgen deprivation therapy to be able to block the hormonal support of the cancer that are feeding the malignant cells, and to allow these cells to be suppressed, which is a variable behavior, because we know that the malignant cells in our body, we know that are aberrant. There are calm illnesses that are stable, and there are other illnesses that quickly look for other options of support and feed to be able to grow, increase, and of course, make the patients more sick. So these times of blocking and tranquility that the hormonal blocking can bring is unpredictable. Nonetheless, it needs to be performed when there are no other healing tools because the patient does not want to receive them, or because we don't have these tools in remote places where we can't count with technological tools to cure the patients, or also in those cases where the diagnosis is too advanced, be it because they went very late into the consultation, or towards them that have an advancement because the illness, despite everything that has been done before, as surgery and radiotherapy, keeps advancing and commits the patient with on a further or a more progressive illness. Now, the therapies could be surgical or pharmaceutical. The surgical is just the extraction of the testicle, cord as orchidectomy, where we remove the main support of testosterone, knowing that at the level of the supral kidney glands, there could be also some kind of support, but it's low. And at a medical level, we have the castration, or this hormonal blocking is done through the implementations of strategies of injections of injectable medications as the antagonists of the luteinizing hormones that allows to make a blockage from the hypothalamus to the testicle to diminish the production of testosterone. Now, mainly the pharmaceutical therapy is offered to most of the patients, especially to those that are young. Obviously, a surgical castration in a young patient could generate a traumatic component that could also alter its life quality. Therefore, the first surgical option is offered to those patients that have an advanced age, to those patients that probably do not want to be submitted to continuous injections throughout their treatment, or also it's important to consider that in certain countries that are in development, and it's that the access to medication that could be monthly, every quarter, or every 6 months could be difficult. And obviously, if we have the social difficulty from the health system of each one of the countries, in this case, the orchidectomy, which is a surgery to extract the testicles, could be the first option. Now, these are the schemes that I believe that we have worldwide, which is the leuprolide, the goserelin, the triptorelin, the antagonist of the hormone that liberates the glucagonist hormone. I think that worldwide we count with these kind of medications are used according to case. It will be used according to the discretion of the physician. We must remember that the antagonist of the LHRH, the degarelix, has its main goal to be used in those patients that have a heart, that have suffered from heart diseases, because the androgenic deprivation that is done through the blockage of the from the hormones, the agonists of LHRH could increase the risk of heart disease, especially coronary diseases. So we must take this into account so we can decrease this risk, and it's equally effective. Additionally, we also have the anti-androgens that makes part of the support of those androgens that allow the feeding of those prostatic cells, and they're in the supral kidney glands. And as a complement, or a strategy of complement, we use the usage of anti-androgens that are peripheric, that are usually oral, like the cioproterone and other illnesses that could be, or other hormones that could be used from the beginning of the stage. But if the illness is advanced with a multiple metastasis and there's a huge risk for the illness to progress, they can be used when there are relapses to the initial treatment, and when the illness, after it was blocked with the analogs of the LH or the antagonists of the LHRH, relapse, recur, or progress, and we need to look for an alternative strategy or a therapy of a second line with these new medications that can block the hormonal influx so they don't reach the prostate, and for the illness to be calmed. And I allow myself to advance a bit of this. This is kind of a small matrix of what we have spoken about before. And with this, I would believe with these last slides, you can see a summary of everything that has been exposed. But this is how I conclude my small conference. I do hope that it was not so complex. And if there is something even more detailed or complex that you would also like to know, I will be paying attention. I will be paying attention to the questions to be able to give an answer. And I would like to remind you all that our center is an advanced center, a center that is located in the city of Bucaramanga in Colombia. Unfortunately, due to the indexes and the standards of safetyness that we have within our institution, we have attained a high standard at a Latin American level, being amongst the top 10 in terms of hospitals in Latin America. We have a urology center that is composed by 8 urologists from the different subspecialties with the purpose of giving an all-in-one treatment to all the patients. We would be more than pleased to be able to aid you all to, in this conference, be able to clarify some doubts, but also in the future be able to accompany you with the patients that you might have, providing the best service, the best human quality, and the best technology. Thank you very much. Dr. Wilmer Rivero, thank you very much. Maria Paula, thank you very much as well. So in this moment, we will start going into the section of Q&A. We have some questions that have been arriving through different channels. So if I'm allowed, I will share with you some of these questions that we currently have. So with this, we will start with the part of Q&A. The first question that we have at the moment is, what's the age to start with the medical checks? Perhaps at the beginning of the conference we saw how the initiation age is associated to the personal and family backgrounds of the patient. Therefore, the recommendation obviously changes depending on the urological societies around the world, but in general terms, it should be determined. And the fact that if we have backgrounds in the family of prostate cancer, we should initiate this revision in an early stage. And the calling is that the patients from their 40 years of age should start the diagnostical strategy for the prostate cancer. But if we don't have any family background at the level of the Colombian Society of Urology, we animate the patients that they started assessing themselves when they have 50 years of age. And if they don't have any infectious pathology in their urine tract, 50 years of age would be perfect. Thank you, doctor. And we have another question that says, if the biopsy is better than the MRI for the diagnosis. Well, the diagnosis has the strategies of complete evaluation and the conformational assessment. So the DRE and the prostatic antigen are diagnostic strategies that are added to be able to get a high suspicion that there is prostate cancer. After the suspicion is there, normally the way that it scales is to perform an MRI where we may identify if that antigen level that is making a suspicion is accompanied with any kind of injury that is showed in an image that can make us think in a cancer. And the next step, if it's present, is to be able to take the indication of performing a prostatic biopsy. Now, the biopsies do not have the risk of dispersing the malignant disease. And we know that these are diagnostic strategies that could be painful, but equally could perform an infection. So the performance of a biopsy needs to have very precise indications, adding the DRE, the digital rectal examination, the physical exam, and the examination of the prostatic specific antigen. Obviously, if I have an antigen that is above 10 points, and I also have an abnormal DRE with a prostatic nodule or a significant deformity or an alteration in the border of the prostate, the biopsy shouldn't wait for the MRA. We can indicate the MRI and the biopsy at the same time because the biopsy would confirm and the MRI will give us the extension of the illness around the prostate, the glands, the prostatic capsule, and the rectal area, because there could also be an invasion of the rectal area on behalf of the malignant disease. Another question that is also related to this preventive side is if a person has a family background in terms of prostatic oncological illnesses, how frequently above the 60 years of age should they perform these preventive examinations? The preventive examinations in those patients that have a background of prostate cancer really don't differ of those that do have it. If we're more than 60 years old and we have the background of prostate cancer, the evaluation is yearly, just as it's done with the patients that don't have the background. The frequency wouldn't change in terms of the evaluation. And an important remark that I give as a doctor and for the patients that have that background of prostate cancer, it's important to take into account the age in which that prostate cancer was present in the family member. That would indicate us to also have another special attention to the evaluation. And my father had a prostate cancer that was diagnosed at 80 years of age or 85 years of age. What we have seen is that probably that family member that could develop the cancer will surely have it at the same year of presentation of his family member. Therefore, if my father had a prostate cancer when he was 50 years old, I should quickly pay attention to that evaluation and perform yearly evaluations that are more precise and accurate, because in many occasions you indicate the yearly evaluation and they start presenting themselves every 2 or 3 years, but effectively it should be yearly. It's an important point. Be in the hand of experts and follow the recommendations. We have another question on behalf of operated patients due to RTU will be free of this illness. The RTU is prostatectomy, and it's an adenectomy of the prostate. Now, the prostate, I always explain that is like a fruit, and it has a layer and it has a pulp. Now, the adenectomy, which is the most common prostatic surgery, is the extraction of the interior of the prostate to be able to deobstruct the urinary tract, the urethra, with the purpose of the patient being able to have a more effective urine process. Now, this procedure is done with those patients that have a greater size in their prostate, and it's done with the purpose of being able to urine. So it's not within the context of the treatment of the prostate cancer, and equally associated to this question, just to give a better or a broader explanation, we must remind that if we're only going to maybe extracting the interior or the pulp of the prostate, let's remember that in the first layer of the prostate, that's the place where the cancers are predominantly present. And more or less a 75 to an 85% of the prostate cancer is presented in the peripheric zone, which is the prostatic capsule, or what is the wrongly call kind of external layer. And what this external layer is left there must be assessed continuously, just as if there was no operation, because there could be a risk of the presence of a cancer in that zone. Related to the benign hyperplasia of the prostate, we would like to ask something. Is that an indicator of a potential cancer? And the complementary one is it recommended that prostatic hyperplasia of a benign illness should be submitted to a surgery? Sorry, Dr. Roman. I felt that I lost a bit my internet. Can you repeat the question? The benign hyperplasia in the prostate, the first question is to know if it's an indicator of potential cancer. And the second one is it recommended in benign hyperplasia of the prostate, is it recommended towards the future? The society, in the Colombian society, between the cancer and this, it's not associated. It's a situation that I explained very well to the patients. In many occasions, the big prostate that is associated to the difficulty to be able to urine is what makes them go into the consultation. And that's the inconvenience, because those that don't have this big prostate do not consult, and they could have a cancer. But the association between a big prostate and having a cancer, there's not directly, doesn't exist. There are prostates that are big and they have also malignant cells. That's a combination of the illnesses, but the progressive growth will not determine a degeneration of the cells and will determine a prostate cancer. That's the first element. Now, in terms of having that prostatic hyperplasia that is chronic, that is presenting itself and generating difficulties, the assessment of this situation, a correct assessment, performing evaluations of the urinary obstruction through laparoscopy and making an evaluation through the functionality of our bladder, because it's also important to know how through the urine how our bladder is working, being able to know if this patient has a blocking, be able to know if they have a complication of the draining of their bladder and their urine methods, and with the purpose of avoiding future complications or obstructions. This must be assessed before we have a really complex situation. They will be taken into a surgical attention that at the moment with the current technology, 90% of them are done through an endoscopy with different technologies, where we can attain successful surgeries of a low complexity, ambulatory surgeries. And we're also trying to decongest the hospitals of so many patients that have problems with the prostates that could take days or weeks after the surgery in the hospital. And with our prostatic hyperplasia, which seems to be a recurrent matter, if a patient with prostatic hyperplasia that aside of this also have within their lifestyles and exercises, they practice bicycling for many years, is there any augmented risk due to this activity to develop any kind of oncological pathology? That is a frequent question, and it really grasps the attention of the people, because the fact of having a compression in the prostatic zone, because it's precisely where we sit when we're sitting and where we sit when we're riding the bicycles, because we sit over the prostatic zone, makes us have an impression that we could be injuring it. But that compression, be it by bicycle, motorcycle, by horse riding as well, hasn't demonstrated that it's really a risk for the prostate cancer, nor for prostatic problems like the hyperplasia. It is important to remember that the traumatisms that we bring to the body in different sites will, of course, generate some kind of resent. So obviously compressing the perineal zone, which is the zone that is between the testicles and the rectum, and that exactly in the middle of it, we have the urethra and the prostate, could generate some kind of a discomfort or symptoms of urinating activities without translating this into an increase in the prostatic size or any malignant present of cells. So it's recommended for the patients to have a better equipment, but not associated to any kind of malignant diseases. So we're already out of time. We want to thank for all of you for giving us this extension of the time with the questions. And we want to culminate with a question: how could the genetic alterations influence, now that we're in a time where the genetic advancement is becoming increased, and the genes BCR1 or BRCA1 and 2 for the indicators of these pathologies, of these non-prostatic pathologies? Each time more, we're observing more academy reports where through different methods, they have been trying to point out the intrafamiliar risks of cancer on one side, and also the risk of illness progression once it's diagnosed. There's been an advancement around this topic, and what's been observed mainly in the advancements in terms of what we could reach us in our region is the advancement of the diagnosis of a genetic risk of a diagnosed cancer in terms of its capability of progressing and the capability of damaging the patient's life. So we do have templates and genetic studies around the pathology that we take around a biopsy, and we may determine how much risk from the point of view of the genetics might that illness have, to allow us to define if the patient can maintain itself in a conservative scheme when we suppose that it's an illness of a good forecasting, and those that do not have a good forecasting cannot be in a scheme of vigilance. We also need to determine what risk exists to progress and also be able to know how we can assume this illness in the treatment plan. So it is a worldwide challenge that is revised in each one of the revisions and in each one of the congresses, to be able to look for all this genetic material and the possibility of studies in terms of genetic tests to be able to try to create a more early diagnosis of the illness, because this goes hand in hand with the fact that we could have better results in the treatments, and obviously it allows us to have earlier treatments as well. Thank you very much, Doctor. We still have some questions that, in honor of time, and of course, to take care of all our schedules, the doctor will be, just to let you all know, the doctor will be responding to our internal channels to all these questions. And we have other topics that are emerging in terms of erectile dysfunction and other treatments that are related with men's health. So we do thank you all. And Doctor, you have had an excellent presentation. And on behalf of VUMI, we would like to thank Hospital Internacional de Colombia, and also thank each and every one of the members of the audience that we have from around the world, and to ask you to please keep trusting in VUMI to be able to manage and aid you in any health needs that you might have. So until the next opportunity, thank you very much, and please pay attention to all the different news and novelties we will be sharing with all of you. Thank you very much.